Well, thank you for that introduction, and thank you for everyone for joining on tonight. It's a little different doing this over video chat, but I think that this is a good option for bringing some good educational material to our local community. So, as Kim mentioned, my name is Stephen Gaeta. I'm one of the physicians here at Inova. I work with the Inova Medical Group, and my focus really is on all different types of cardiac arrhythmia or heart rhythm disturbances. But a lot of my time is spent thinking about atrial fibrillation, both scientifically as well as clinically, and how to better care for our patients. I do serve as the director of outreach, and I provide care for atrial fibrillation patients as well as any number of other cardiac patients across Northern Virginia, primarily both in Falls Church area here in Fairfax at the Innovation Center with Inova, as well as out in Alexandria at the newly opened Mark Center. So with that, I thought we could get started. I have some slides that I prepared for this talk tonight, but really I was hoping to keep this a little bit more casual, sort of like I would do in clinic. So a portion of this I'll do almost as a whiteboard type talk using Zoom. So I'll share my screen here. And I wanted to just start off by actually talking about what atrial fibrillation is. The overview of the talk tonight will be talking about what it is that causes atrial fibrillation, what it feels like, and then a lot about why we care about atrial fibrillation and what options we have to do about it, including from the physician's point of view, how I can help you, but also from the patient's point of view, what you can do to help prevent atrial fibrillation or help to manage it. So as I said, I'm going to try to do this as a whiteboard type talk. And so here, hopefully you can see what I'm drawing here, but when we think about atrial fibrillation, we think mostly about the left atrium of the heart. So if this is the left atrium of the heart here, it's connected to the bottom chamber of the heart, the ventricle, by the mitral valve. And normally your heart knows when to beat because there's a wave of electricity that spreads across that top chamber of your heart in a one-way street. That's what tells your heart when to beat, and it's how we see your heart function on an EKG. Give me one moment here to try and get back those controls. Okay, good. So that's what your heartbeat normally looks like. In atrial fibrillation, what happens is that there's some extra sparks of electricity that come into your heart, and they spread into the rest of your heart as a wave, and they break up that normal, nice, controlled wave of electrical activity into a chaotic and disorganized mess. And so this is what atrial fibrillation actually is. It's essentially this chaotic activity where the electricity that tells your heart when to beat is going in all different directions. That's what causes the symptoms of Afib, as well as the other outcomes issues that we care about. And that can go on for a few seconds. It can go on for a few minutes. It can go on indefinitely until you get some help being taken out of atrial fibrillation. So part of the reason why atrial fibrillation causes symptoms is that when this is happening, that top chamber of your heart is going as fast as 600 beats a minute, and it's going very irregularly. Now, obviously, your pulse, which comes from that bottom chamber of your heart, isn't going 600 beats a minute or you would lose consciousness, but your pulse is usually quite elevated and it's usually very irregular, and that's what causes some of the symptoms of atrial fibrillation. So if we go back to those slides, we can talk first about the fact that many of you on the phone call tonight are presumably interested in atrial fibrillation because it's something you're currently dealing with. And one piece of good news is that you're not alone. Atrial fibrillation is extremely common. In 2010, there was about 5 million Americans that had atrial fibrillation, and it's projected to go up to over 12 million by 2030. That growth in atrial fibrillation is both because of changing demographics of our population. People are getting older, obviously. There's some more cardiovascular related conditions that we're seeing, but also because we're just getting better at detecting atrial fibrillation and detecting it early using many times wearable EKG monitors like some of those you all probably have at home, Apple Watches and cardio monitors and so forth. Atrial fibrillation can occur really at any age, but the majority of my patients are between 65 and 85 years old that have atrial fibrillation. The good news is, and we'll come back to this point again, is that atrial fibrillation and its related condition, atrial flutter, are usually not life-threatening issues if they're treated properly. So if treated properly, atrial fibrillation becomes a quality of life issue, not a quantity of life issue. I apologize, these slides got out of order here. So let's talk a little bit more about the normal course of atrial fibrillation and what you can expect with AFib. As I mentioned, atrial fibrillation, let me see here. Sorry, some technical issues. Atrial fibrillation comes from those extra beats that come from somewhere inside the left atrium. This is an actual piece of clinical data. This is the type of pictures that are generated when we do some of our procedures for atrial fibrillation. This is a three-dimensional model of that top left chamber of a real patient's heart. And you can see the four pulmonary veins coming into it. This is just to remind you guys that that little cartoon I drew is actually pretty realistic. This is what the heart is really shaped like. And I'll come back to this image a few times, but this is actually color coded based on how healthy the tissue is. And this is a normal heart. This is one where in purple, you're seeing nice healthy tissue everywhere. And then as you go out to those veins, you start to have normal vein tissue, which is in this case colored red. So what does atrial fibrillation feel like? Many of you on this call probably don't need to be told, but it can have a very wide range of symptoms. Many of my patients have no symptoms at all, or at least they say they have no symptoms when they come in, although I would speculate that most people with atrial fibrillation, if you actually challenge them by putting them on a treadmill or otherwise asking more of their bodies, most people would find that they're not able to perform quite as much as they usually would. The majority of people who do feel symptoms complain of palpitations. Fatigue is a really big one. Many times people come into my clinic saying they feel like their heart is just kind of stuck in the wrong gear, or they thought that they were getting old. And while everybody does get old, sometimes you're not as old as you thought you were. Some shortness of breath is very common. And then there's a variety of other conditions that you can find. In general, the symptoms of atrial fibrillation are relatively mild. And most of the time, people don't have to go to the emergency room to have their atrial fibrillation controlled. Basically, the times I tell people to go to the emergency room for atrial fibrillation are really only three conditions. It's if they're having severe chest pain associated with it, if they're passing out from their atrial fibrillation, or if they really can't catch their breath. And for most patients, that's not a situation they find themselves in. Atrial fibrillation is progressive. As I said, those spurts of irregular, chaotic electrical activity in that top left chamber, they can come and go. They can last seconds, minutes, or longer. In the beginning of the disease process, typically you have what's called paroxysmal atrial fibrillation. Just means atrial fibrillation that starts and stops on its own. And by our definition clinically is usually within about 7 days. After that, the disease tends to get worse. It tends to have these episodes occur in a higher frequency. They come more often, and they tend to last longer when they do stick around. And eventually, those episodes of atrial fibrillation don't stop on their own. And that's when you get into this category of persistent atrial fibrillation. And then eventually, if you're in atrial fibrillation continuously for a long time, you become what's called long-standing persistent. These are clinical definitions that help us to put patients into different categories and to think about their prognosis and what treatment options we have. But it's actually worth mentioning that these really do correlate to changes inside of your heart. So atrial fibrillation, when it stops and starts, that's a heart that doesn't really want to be in atrial fibrillation. It's a heart that keeps getting put out of rhythm by those extra sparks of electricity, those extra beats, but it really doesn't want to be in AFib. The longer you have AFib, though, the more your heart changes to actually continue to be in AFib. And you'll see some pictures of that in a bit. And that's what leads to persistent atrial fibrillation is scarring or changes in the size and shape of your heart that occur over time with atrial fibrillation that tend to promote continued atrial fibrillation and make it, unfortunately, a lot harder to deal with. And one of the punchlines of what I'd like people to go home with tonight is that the earlier you start to deal with atrial fibrillation, the easier it is and the more successful you can be in trying to get rid of it. As I mentioned, this is a progressive disease, and about 1 in 5 patients progress in the first year from paroxysmal atrial fibrillation, where it stops and starts, to persistent atrial fibrillation. And one of the main reasons why we are aggressive about treating atrial fibrillation is to try to prevent that transition into the persistent atrial fibrillation that is associated with worse outcomes and can be much, much harder to get rid of. So returning back to that picture of the heart again, this is what a paroxysmal atrial fibrillation heart looks like, one that stops and starts with atrial fibrillation. It's a healthy heart, and it really doesn't want to be in atrial fibrillation. This is, again, another piece of real clinical data from a different patients looking at their left atrium. And this is an example where it's color-coded again by scar tissue, where purple is healthy and shades of yellows and reds indicate areas of scarring. And you can see that this patient who had been in atrial fibrillation for a long time, that they start to see some damage to their heart that we characterize as scarring. And it gets a little bit beyond the scope of this type of talk, but those areas of scar are very much related to why atrial fibrillation starts and how it's able to continue over the long term. So, why do we care about atrial fibrillation? Well, there's really two main reasons, but we'll go through some details on them. And overall, the goal of someone like myself when I treat atrial fibrillation patients is to provide comprehensive care for atrial fibrillation that's specific to the patient in front of me, with the goals being to improve the quality and the quantity of life for atrial fibrillation patients. The two main goals of treatment really are to reduce the risk of having a stroke in atrial fibrillation and then to improve quality of life by decreasing symptoms. You can sort of break it down more than that, but those are the big picture issues. So, starting first with the idea of stroke prevention, this is a very important topic. Um, Whenever somebody with atrial fibrillation comes in, the first questions that I ask are related to whether or not this is somebody who has a very high risk of having a stroke. The reason why atrial fibrillation can cause strokes is that when your top chamber is going 600 beats a minute and irregularly, it really isn't squeezing very well, and the blood inside of it can pool and form a blood clot. And if that blood clot travels to your brain or somewhere else in your body, it can cut off blood flow and cause a stroke or other complications. So the first questions that I ask when someone comes into my office with AFib have to do with what other risk factors they have for having a stroke in addition to atrial fibrillation. If atrial fibrillation is your only risk factor for having a stroke, many times the risk of stroke is low enough that we don't need to do anything specific to treat it. For people who have other risk factors for stroke, of which I'm thinking about congestive heart failure, being older than 65 years old, a history of high blood pressure, diabetes, prior strokes in the past, vascular disease like coronary artery disease or peripheral arterial disease, or unfortunately, some risk factors that people can't help, like just being a woman. Those risk factors can tip you over the edge where your risk of having a stroke with atrial fibrillation is high enough that we'd recommend trying to treat it with a medication to reduce that risk. So the bad news is that the medications we have for reducing your risk of having a stroke, we don't have a really great way to get people off of those medications. For most people, it's a lifelong treatment to help reduce the risk of stroke. But the good news is that the medications we have in 2020 are very, very effective at reducing the risk of stroke, more than an 80% reduction in the risk of having a stroke. And they're much more easy to tolerate than the medications we had in the past. Many of you may be familiar with Coumadin. Luckily, we're really not using Coumadin very often anymore because it was such a difficult medication to take and was not even as effective as the new medications we have in reducing the risk of having a stroke. So that's step one always, is to really focus on that most important factor of treating AFib and preventing strokes. The other aspects of treating AFib are primarily around improving quality of life and reducing symptoms. There are some contexts, namely people who have a weakened heart at baseline, where reducing atrial fibrillation or eliminating it is actually associated with improving your lifespan as well, reducing mortality. So for those patients, we're quite aggressive about trying to treat their atrial fibrillation. It's also important to remember, as I mentioned, that AFib is progressive. It gets worse over time, and early treatment of AFib can help to prevent that progression and prevent downstream associated conditions like dementia and other problems. So, how can we treat atrial fibrillation? What are the options? Well, the first option is that we can simply allow atrial fibrillation to occur, but make sure that when it happens, your heart rate doesn't go too fast. That's called rate control. And it doesn't really get rid of the atrial fibrillation. It just helps to mitigate some of the symptoms and some of the possible adverse effects of being in AFib by making sure your heart rate doesn't go too fast. Primarily, this is done using medications that I'm sure many of you are familiar with, like beta blockers or calcium channel blockers or others. This, as a strategy, is something that our field is starting to move away from somewhat, at least earlier on in atrial fibrillation. There are many patients still where this is the best option, but for most patients, we're finding that trying to get you out of atrial fibrillation and keep you out of atrial fibrillation is important for reducing hospitalizations in the future, for improving your lifespan, and preventing other problems that can arise down the road. It's also important because if you leave someone in atrial fibrillation, as I mentioned, the longer they're in AFib, the harder it gets to get them out of it. So that means that if down the line the symptoms become worse and there's now a desire to try and stop the AFib, it can become a real challenge if you've been on a rate control strategy for a long time. Now, again, that's not to say there aren't patients for whom this is the most appropriate therapy. There certainly are, but more and more our field is starting to recognize that it's important to try to stop AFib early on. So how can we stop atrial fibrillation? Well, there's basically three options. There's a shock called a cardioversion, there's medications, and then there's an ablation procedure. I'll touch on these briefly, but perhaps as we go through some of the questions, we'll have more to say about them. So the shock is called an electrical cardioversion. This is an extremely effective way of stopping atrial fibrillation. It's basically where we put people to sleep for a few seconds, and while they're asleep, we deliver usually a single shock using pads on their chest that resets their heart into a normal rhythm. It's extremely effective, but it also doesn't do anything to stop the next episode of atrial fibrillation. Sometimes this can be done using medications instead of the shocks, but typically this is done with an electrical cardioversion, the shock. So this is a good option for somebody who has infrequent episodes of atrial fibrillation, but when they have an episode, it will continue unless they're helped to get out of it. So that's one strategy. It's only a good strategy for people who have infrequent episodes. You can't do this too many times or you're really going to be exposing yourself to potential harm. So if for people who have longer episodes of AFib, more frequent episodes of AFib, we start to think about medical therapy or the procedural therapy, the ablation. So medical therapy involves one of about 6 different medications that we can prescribe either on an as needed basis in some cases, or more commonly on a daily basis, where you take a medication in order to suppress those extra beats that I mentioned that can help to trigger atrial fibrillation. So the goal of that therapy is to provide a medication that improves your quality of life by reducing your episodes of atrial fibrillation. This is, again, another good option for many patients, and it's most oftentimes, this is our first line therapy, is to prescribe a medication. There's also the option of a catheter ablation. This is something that is becoming more and more common, and it's already quite common in the United States, and in our practice, I do about 150 or so of this type of catheter ablation for atrial fibrillation, as well as ablations for many other conditions each year. A catheter ablation is a minimally invasive procedure done through IVs in the leg, where essentially we put you to sleep for the procedure, and then using those IVs, we put some catheters up into the inside surface of your heart. Catheters are just thin, flexible tubes with electrodes on them that we can use to measure electrical activity and to make those pictures of the heart, those models of the heart like you saw earlier. Once we have identified the anatomy of your heart, we then use the same ablation, the same catheters to actually cauterize areas of tissue within the heart that are with a goal of stopping those extra beats from triggering atrial fibrillation. So in the case of the picture that I drew earlier, these red dots here are a pretty standard atrial fibrillation ablation procedure. Each one of these spots is an area where I cauterized. And so the goal here is to essentially make a wall of scar around those pulmonary veins, those 4 veins in the top left chamber, which are the most common site of those extra sparks of electricity. And if you have a complete wall of scar, those extra sparks of electricity can't get out into the rest of the heart and trigger episodes of atrial fibrillation. So this procedure is called a pulmonary vein isolation procedure, or a PVI, and it's really the cornerstone of what we do for atrial fibrillation from a procedural standpoint. There are different techniques that become involved when people have recurrences of atrial fibrillation, if people have very long-standing persistent atrial fibrillation, or if they have other related heart rhythm issues. But this is really the bread and butter of what we do for atrial fibrillation. Finally, there are some hybrid therapy approaches that involve medications as well as ablations, or even surgical procedures in addition to the catheter procedures. We'll kind of leave that on the side for right now unless there's specific questions. But the idea is that if you have atrial fibrillation and you're interested in improving your quality of life by decreasing your symptoms of AFib, the options on an ongoing basis are really either to use a medical approach with different medicines, or to perhaps use an ablation procedure to try and get to the same endpoint without needing to use medications. So that's what I can do to help people with atrial fibrillation, involving medicines and procedures. But an important question is, what can patients do to help themselves? And this really gets to what are the underlying causes of atrial fibrillation. I'll be honest that AFib for many people is really just a badge of honor for reaching a certain age. This is something that happens inside of our hearts as we get older. when we have differences in the shape and size of our hearts or small amounts of scar tissue that are deposited. So it's a very common problem that sometimes there is no smoking gun of something that went wrong that caused it. But there are things that we know are very clearly associated with atrial fibrillation that sometimes we can do things about. The first is being overweight or smoking. Those are general cardiovascular health issues, and the heart is a muscle like any other in your body, and it wants you to be in good cardiovascular health. So the good news is that if you address these things by quitting smoking or by losing weight, you really can reduce your recurrences of atrial fibrillation. Alcohol consumption is related to atrial fibrillation. I usually tell patients that the more you drink, the more atrial fibrillation you'll have. Complete abstinence is a very hard goal to shoot for, but the good news is that even just decreasing your alcohol, if you drink a lot of alcohol, can help to prevent or reduce the number of recurrences you have. Caffeine consumption can at times be related, though it's not 100%. Stress is definitely related, anxiety, so forth. There's other conditions in your medical history that may be related to atrial fibrillation. History of heart failure in particular, valve disorders like a leaky valve be related to atrial fibrillation. And then finally, things that you can't help, like just being older, family history, or other genetic factors. And then unfortunately, it's related to, it's predisposed in men over women as well. So that's really what I had to say tonight in terms of prepared remarks, but I'm very happy to talk about any questions that you have and to continue the discussion in whichever direction makes sense.
Thank you, Dr. Gaeta. We're now, as you mentioned, we're going to open up the floor now for questions that have been submitted. We did have a couple that came in advance, but before I get to those, as a reminder, you can still submit your questions in the Q&A box, or you can use the little button to raise your hand. But the first question, Dr. Gaeta, we have advanced question that came in was, oh, I'm going to butcher this word. I have paroxysmal Afib, probably said that wrong, and I'm taking metoprolol 150 milligrams daily along with Xarelto 20 mgs. I still occasionally feel the Afib lasting a few minutes to an hour. Should I be taking a drug to maintain heart rhythm?
Okay, that's a great question. So to repeat the question, it's saying this is someone who has paroxysmal atrial fibrillation that stops and starts, who's taking a medication, metoprolol, to help reduce the rate of the atrial fibrillation, as well as Xarelto to help reduce the risk of having a stroke. And the question is, they're on a rate control strategy with the metoprolol to reduce the rate of atrial fibrillation. Does it make sense to do a rhythm control strategy to try to get rid of the atrial fibrillation entirely? There's a lot that goes into that decision, and some of this has to do with what your underlying other cardiac issues may be that would push you in one direction or the other, as well as what your quality of life is currently. So for somebody who has a completely normal heart with really no other medical problems going on, occasional episodes of atrial fibrillation are not a terrible endpoint to have. That's something that's okay as long as your quality of life is all right. If your episodes of atrial fibrillation are stopping and starting and your quality of life is okay, that's a reasonable place to be. I will say that, again, more and more these days, we're starting to say that almost everybody, though, who has AFib, that on the whole, people do better when we do try to actually stop those episodes of atrial fibrillation. And the metoprolol pretty much is not doing that. So in general, my answer would be yes, I would recommend trying to treat that, especially if your quality of life is not where you feel it should be, or if you have other cardiac issues that would make it more important, like a weakened heart, other cardiovascular disease, and so forth. I hope that answered your question.
Thank you. Second question we have, will paroxysmal AFib lead to consistent AFib? And the second part of that is, will it lead to heart failure?
It's a great question. So will paroxysmal atrial fibrillation lead to persistent or continuous atrial fibrillation? The answer is that yes, typically the longer you have atrial fibrillation, the longer your episodes of AFib will be, and the more frequently they'll occur. And eventually they do tend to become persistent or continuous. So that's part of why it's important to try to get on top of atrial fibrillation and treat it early, is to prevent that transition. Because once you get to the point where your AFib is continuous, treating it gets a lot harder. We still have all the options I mentioned about medical therapy or procedural therapy, but the success rate for those procedures gets lower and the difficulty becomes higher in general. There's another part to that question too, is that right?
Yes, will it lead to heart failure?
Will it lead to heart failure? Thanks.
Mhm.
In most people, the answer is no. If your heart rate is well enough controlled with atrial fibrillation, in general, with an average rate less than about 100 beats a minute, most of the time people will not have heart failure as a result of their atrial fibrillation. Um, sorry. But if you have heart failure to begin with, if your heart is even a little bit weak, then atrial fibrillation can worsen your heart failure, lead to more hospitalizations for treatments, and can in general just make it a much more difficult course.
Okay, great, thank you. I'm going to move to a couple of questions in the chat, and then I'll come back to some of the advanced questions. I had orthopedic surgery recently, which included 2 EKGs and a heart monitor for several days. Would this have picked up AFib?
So the hard part with atrial fibrillation diagnosis is that you have to catch it when it occurs. And when it's not happening, it's hard to know that it ever happened in the past. So for atrial fibrillation that comes and goes, the longer you look for it, the more likely you are to find it, if that makes sense. So if you were monitored for a few days, it would mean that you're definitely not having continuous atrial fibrillation, and you may not be having a lot of it. But if somebody had a clinical suspicion that you may have atrial fibrillation, for instance, if you had a stroke and we were trying to look for whether or not you have very rare episodes of AFib, then we would typically prescribe longer term monitors, things like a 14-day or a 30-day event monitor, which fortunately these days are just stickers, not any wires and clunky things to wear. Or for some patients, we even put in what's called an implantable loop recorder, which is a small monitor the size of a few matchsticks that we insert underneath the skin on the front of your chest. And that can actually monitor for atrial fibrillation for as long as 3 years. So to answer your question, the heart monitor for several days would have picked up atrial fibrillation if it occurred during those few days. But if somebody had a high concern that you have AFib that they're missing, they might want to look even longer.
Okay, great, thank you. Next question. Is there much difference between different medicines? Can there be a benefit from changing from one medicine to another medicine?
So there are differences between the different medicines. And the first way we make the decision about a medicine is typically looking at what else is going on with your health, because there are conditions that can exclude certain medications that we know we can't use. So for that reason, we typically have first line medications that we would start with, and then there are second line or even third line medications if for some reason we can't use those other ones. There are differences for different people in how they make you feel and in the safety of different medications, but in general, they're all fairly safe. Can there be a benefit from changing from one medicine to another? The answer is yes, there can be, but typically speaking, if you have started taking one of these medications to stop episodes of atrial fibrillation and it's not working and you continue to have episodes of AFib, switching to another medicine is unlikely to be helpful. And that's a really good stopping point where we really start to think about offering an ablation procedure because of how unlikely it is that a different medication would work in that situation.
Okay, great, thank you. Hopefully, Dr. Gaeta, you can understand this one. Which procedure is better, freezing or RF?
Yeah, that's a great question. So that question is asking, there's 2 different ways to do that procedure that I showed you, where we make that wall of scar around the 4 pulmonary veins in the top left chamber, that pulmonary vein isolation procedure. One way is to use radio frequency energy, which is what I described as cauterizing, and that's to make that area of scar. A second way to do it is by using a freezing balloon or a cryo balloon technique. And that's where instead of using heating of tissue to make scar, we actually freeze the tissue to make scar using a balloon that goes into those veins. Looking at the data about how effective the 2 different approaches are, there's really no difference between the 2 approaches. So I can't strongly recommend one versus the other. You want to do whatever the person who's treating you is most comfortable with. I would say that's the most important thing to say here. Atrial fibrillation is a progressive and recurrent problem. So if in the future you already had one procedure and you're going back to try to address any problems that have arisen in the future, that would definitely be a time where most people would use radio frequency energy as opposed to the freezing balloon, because the freezing balloon is a one-shot procedure that essentially freezes everywhere at once and it's not particularly targeted. whereas a radio frequency procedure uses a catheter that's a few millimeters across to be very pinpointed where you're actually doing the ablation. So it's a great question.
Great, thank you. The next question is amiodarone a viable drug for irregular heart rate? And if so, for how long?
Great. So amiodarone is, I usually say it's our best medication and it's also our worst medication. Amiodarone is a medication that we use in a lot of different contexts, but as a long-term therapy, it's typically our last line that we would use. We'd opt for other medications first. The reason is that although amiodarone is very effective at reducing atrial fibrillation or getting rid of it entirely, over many years of use, it can have toxicity that accumulates in your thyroid, your lungs, or your liver. So for that reason, we typically don't like to put people who are young on amiodarone, and we would try to find a different solution before we settle on that as the final long-term approach for managing atrial fibrillation. Now, all that said, the toxicity associated with amiodarone, if you Google it, you'll get scared, just like you would with a lot of medications. But many of those side effects that we see are really from days where we used much higher doses of amiodarone than we used in the past. And nowadays, we have a much more stringent monitoring program to watch for those issues with your thyroid, your lung, or your liver, so that we can catch any issues that come up early and then address it. So all said, I would say that amiodarone is a great medication, but it's also not one that we try to keep people on for very long. I will commonly use amiodarone around the time of an ablation procedure because it can help to prevent any episodes of atrial fibrillation occurring around the time of the procedure just from inflammation. And I usually would try to limit it to about 3 months or so, but there's not really a hard and fast rule. And a lot of it has to depend it depends on where you've been before, what medications you've tried that haven't worked, if you've had an ablation before, and a lot of other factors.
Thank you. I'm going to get to this last question in the Q&A, and then I do see the chat questions, and we'll get to those.
Great.
So this last one says, and again, I may butcher this medication name, I am on flecainide now to control my AFib. Will the positive effects of this medicine last forever, or might I have to have a surgical intervention at some point?
So good question. Very hard to predict. So flecainide is one of our most common medications that we use to reduce those extra heartbeats that trigger atrial fibrillation and to prevent recurrences. And there are people who do very, very well on flecainide with long-term success with that medication and with low side effects. So it's a very commonly used medication. It'd be impossible for anybody to really promise that the effects will last forever. The reason being that AFib really is unfortunately related to some things that are just about getting older, scarring in your heart, some stiffening of the heart or enlargements, and those things can continue even if the flecainide is already there. So in general, I'd say that there's a really good chance that at some point you would have a recurrence, even if you're on flecainide now. But you know, we've all been surprised in the past, people who do well for years and years and years, and I certainly hope that you're one of those people.
Great, thank you. Let's see here. I have heard that COVID patients are experiencing heart arrhythmias post-recovery. Are you seeing an increased incidence of AFib with COVID patients?
Not really is the short answer. There's been a lot of back and forth about how significant the heart effects of COVID really are. We've certainly seen in our experience here at Inova, we've seen some patients with very severe heart manifestations of COVID, but in general, we're not seeing that there's a huge amount of new arrhythmia that's coming out of those patients. So it doesn't mean that it's not something to consider, but at the same time, usually the arrhythmia aspects of COVID are the sort of less important aspects of what's going on in someone's health. If you have a diagnosis of atrial fibrillation already, anything that stresses your system can very commonly cause a recurrence. So I wouldn't be surprised if you're somebody who already has AFib, if you get sick with really anything, if you have a recurrence of AFib around that time. But as a cause of atrial fibrillation, it's not something we're seeing a ton of.
Great, thank you. I've had atrial clip procedure. Do I still need to fear stroke?
So the AtriClip is a procedure that's sort of a cousin to the left atrial appendage occlusion device, the Watchman device we mentioned earlier. An AtriClip is a surgically placed clip that actually essentially clips off that left atrial appendage, that sac where so many of those clots that come from atrial fibrillation, that cause strokes and atrial fibrillation come from. So this is something where there's not a lot of data to guide us on this about whether you are completely in the clear after you've had one of these types of devices or whether there's some residual risk of stroke. I'll punt a little bit and say that a lot of it has to do with any other risk factors that you specifically have. There are many patients that have some sort of an appendage procedure done, like an atrial clip, where we do take them off their blood thinners after that procedure is done, but it isn't true 100%, unfortunately.
Great, thank you. I'm going to switch back over here to the advanced questions, and I'd like to just let the audience know if you have any more questions, feel free to put them in the chat or in the Q&A. Let's see here. Since I am on metoprolol, 150 mgs, should I never fill the AFib?
So that's a great question. And so what this really gets to is the quality of life aspect. It's hard for me to tell you what your quality of life is or what your quality of life goal should be. There are people who have occasional episodes of AFib and they say that they're where they want to be and this is totally fine for them. I would say most people get to a point at some point where they say enough is enough and they start worrying about when their next episode will be, or they start realizing that it's limiting their life and other things they want to do when they have these episodes, and they say it's time to treat it. And the other thing is that I would say in the last couple of years, especially, we're really starting to learn that probably the best strategy for everybody is to try to stop those episodes of AFib entirely with medications or procedure. But that's an evolving story, and a lot of it has to do with who you are, what your goals of care are, and what your quality of life is like at this moment.
Thank you. Next one. My father had left bundle branch block. Is my AFib related to that?
Probably not directly. Left bundle branch block is a problem with the wiring of the heart, really the wiring in the bottom chamber of the heart. And it can have issues that arise from it that have to do with your heart not really beating as one in sync. It's not typically related to atrial fibrillation, which comes from the top chamber of the heart, other than oftentimes the same types of cardiac issues can underlie both of them. If you have heart failure, if you have high blood pressure chronically, those sorts of things can lead to left bundle branch block, just like they can lead to atrial fibrillation. The good news is that if you've had EKGs, they would already have shown whether or not you have a left bundle branch block at this moment. And although it can happen again in the future at some point, you don't have to worry about it if you don't have it right now.
Thank you. My mitral valve is mild to moderately, quotes, leaky. Is this causing AFib?
So mitral valve regurgitation or leaking mitral valve is definitely related to atrial fibrillation. If we go back very briefly to that picture that I drew up here earlier, that valve that I drew there is the mitral valve. And so what this valve does is it lets blood go from the top chamber, the left atrium, down to the bottom chamber, but it's designed so that the blood can't flow backwards. So it really lets the blood go this way, but not backwards. What can happen is that if you have a leaking mitral valve, then with every heartbeat, some of the blood flows back up into that top chamber. And the reason why this is important is that when that happens, it actually increases the pressure inside of that top chamber, and it can cause it to actually enlarge. So that top chamber will get essentially stretched out, will get stretched out and enlarged, and that can lead to irritation of the heart, where you start to have more extra beats that get fired off from different spots. You start to have, little irritated spots of tissue that arise from these stretched out areas in different parts of the heart. So what that means is that when you have a leaking mitral valve, it can cause more of those extra heartbeats that trigger atrial fibrillation, cause your episodes to be more frequent or longer in duration. The hard part is that atrial fibrillation can also impact the squeezing of your heart and make mitral regurgitation or a leaking mitral valve worse as well. So it can be kind of a vicious cycle where mitral regurgitation causes more atrial fibrillation causes more mitral regurgitation, and so forth. So the short answer is that yes, I would say that atrial fibrillation is definitely related to your mitral valve. It can make the leaking mitral valve can make the treatment of AFib, unfortunately, more challenging, though not impossible, but they definitely are probably related in some way.
Thank you. This looks like this may be the last question. I am on to Tyson, but it makes me very dizzy. Is there something else I can take, or should I get the ablation?
So good question. So Ticasine is one of our medications that's really pretty good for treating atrial fibrillation. This is a good example about how these medications that have effects on the heart can have effects anywhere in your body, and different people can have different types of side effects, including dizziness or other things. The decision, really about when it's time to pursue the ablation, I think it's reasonable to say that if you're trying medications and medications are either ineffective for you or you're not able to tolerate them, that is a time to have a discussion about whether an ablation is the right next step for you. There are other medications that can be tried, certainly, but I find that typically speaking, when somebody is having a real struggle with one medication, that switching to another one, oftentimes it's not a very different story at that point. So nobody is, everybody's different, and it's hard for me to know with your health specifically what makes sense, but it is the right time, I'd say, to start talking about whether that's a reasonable approach for you.
Great, thank you. Well, at this time, I don't see any other questions in the chat. I don't see any in the Q&A. We've gone through all of our advanced questions. So I think at this time, we'd like to just extend a big thank you to you, Dr. Gaeta, for your time. We've learned a lot this evening, and we just thank all of you for attending tonight's webinar. If you have any questions, feel free to email Champa. She just put her email address in the chat box. And then once you leave today's seminar, you will see a survey that pops up about this presentation. We'd appreciate it if you can just complete that and just provide your feedback. And then you will also receive a follow-up email within the next 48 hours with a link to view today's recording of this webinar. And on behalf of Inova, thank you for joining us. Thank you, Dr. Gaeta, again for your time. Thank you, guests, for your time as well. And to my colleague, Champa, and I wish everyone a good evening.
Thank you all very much.